on our experience and our journey in developing the EMR and our 12 years of learning on that journey. Although within the private sector, we're very happy to share our experiences, and we're delighted that we were invited here today, because I do believe that a lot of the lessons and experiences are extremely transferable, and we are above all nurses. So the vision from the onset, the opening of the Galway Clinic, was that it would have a strong leaning towards technology and electronic solutions in all aspects of patient care. And we had a purchased vendor when we arrived. I arrived in 2004 on site, and we had an electronic medical record purchased. And what we now have is an integrated EMR, which is completely integrated across all disciplines within the organisation, with added components continuously on our journey being added onto the EMR. But they all have to connect, because connectivity is everything, as is communication. So every discipline uses the EMR, but it has not been a very seamless journey. We've had problems, we've had challenges, some of them complex. On occasion, it has been like Flanagan's Bowl, where one discipline will step in and another will step out, till we all got on the same path. And now we have it, and it is working, but it is still work in progress. And we're now at the stage where we're hitting into an upgrade or a second generation of our EMR, and it is now allowing us to do all the things that we really, really want to do and change and develop. So the challenge in 2004 was, as I said, we had an EMR purchased. And at that time, when I arrived and I looked at, okay, we've got a vendor, the product is Meditech, there it is. Every bit of research that I looked for was coming from the States, from all the Kaiser Permanente hospitals and from all the veteran hospitals. So this was our product, and this is what we were going with. And a team came with the product to help us develop it, build it, populate it, help us navigate our way through it, change what we wanted to do, etc. And I had an initial fear on arriving and seeing the product and seeing the team that were coming to help us, that they didn't understand us. It wasn't Irishized. And I had a fear that all the nursing and other discipline staff were going to be talking about appendectomies, on gurneys, and all this kind of thing. Because that's kind of what hit me first on my first interaction with it. So we had to do quite a bit of work on building it, and I've learned a new language as I have developed with the EMR, because now we build everything, we navigate, we populate, and this is just natural language for us within the clinic with our EMR. We had a lot of other things we needed to do with it, because, as I said, we needed to Irishize it into our own context for our own on-board automation at that time. And we had to look at the documentation that was there, because my initial experience was that it was developed from a very medical model rather than a nursing model. So that took quite a long time. I would say within the 12 years, we're still correcting some of that on our journey. But what that experience has given us is an absolute dearth of knowledge in relation to how to build, how to adapt the systems, how to implement an EMR, and a lot of what not to do as well. And Michelle coined the phrase learning on the run, and I would definitely say that's what we've experienced. Our key lessons in the last 12 years, first and foremost, without our IT colleagues who are nurses, we would definitely not be where we are. So Winnie and Jackie, I would say, are two of the most valuable people in the Galway Clinic. They understand us. They understand when nursing are talking. They understand when nursing just aren't satisfied with what we've got. And they're able to translate that into the IT language and translate it into our Meditech language as well. The first assumption that what you have on paper will automatically translate into an electronic format has to go in the bin. That does not work. Time and time again, we see different things come to us that we would say we'd like that to work in our records, we'd like it to be part of our records. It doesn't. And you can try and do workarounds, but sometimes workarounds don't work either. Because what you want and what you want to build must have value. It must be meaningful. And it must be there that you can get it out again in a different format if you want it for audit purposes. Ongoing nurse education is absolutely critical to the ongoing correct use and support of the system. And I don't just mean on orientation when a new member comes to the team and they're developing and they're learning about our EMR. The staff and their interaction with our electronic medical record have often been the solution to many of our problems. They see, they can innovate very quickly. This will work better. This will navigate into something else. More importantly, as Michelle and Winnie will talk about, we identified through our journey that we needed to have a standardised nursing language, and our Generation 2 is really honing in on that. Reports. If you plan on getting something out of it, you need to put it in and build it. Just because it has all this vast amount of information, it may not easily be retractable out. So as you build, you need to be able to identify audits, information, any kind of data that you intend taking out again. You need to build that into the system at the very early stages. A very simple thing, sufficient hardware and resources. We call our carts cows, carts and wheels. You need to have enough equipment. You need to have enough scanners, and you need to have them accessible to the right people. And the most other thing that we found challenging within our journey of our EMR is interfacing with other primary systems or other electronic systems that might come along. For example, electronic vital signs, which we have now rolled out within the hospital, electronic prescribing. If they don't interface with your primary vendor, it is going to be difficult to have a seamless EMR, and you're only stepping back in your journey of where you're planning to go. So.
Excuse me. This is where I step in. Sinead then asked me to help to look at the overview of Generation 2, the nursing documentation, as part of our new, what we call e-Curriculum. So really we're rebuilding our EMR from the ground up again. And it was absolutely imperative that we had all of the key elements that we needed within the lessons that we learned over the last 12 years. I wasn't there, but all the information that we had, that we would actually be able to build on that and develop what we wanted now. So really the goals were that we have a provision of a comprehensive holistic record of assessment, planning care and interventions, and the evaluation of the care delivered. It's fairly straightforward. We wanted the documentation that meets the legal and professional requirements, criteria defined in the Nurses Act and the NMBI guidelines. And of course we're accountable to our JCI standards, so also meets our JCI standards. That incorporates an international nursing language and provides evidence of person-centred nursing practice, which is our model of practice that we've adopted in the Galway Clinic, which was developed by Brendan McCormick and Tanya McCants in the University of Ulster. Includes the use of person-centred language in the preset content that will in turn support person-centred practice. Okay. So, how to reach an elephant. It is massive. I came from the public sector. I worked in the HSE for a long, long time. I had no comprehension of what was involved in this. It was because literally we had to break down every single word that we use within the documents. We were lucky because we're already using an electronic document. So we know what works and we know what doesn't work, and we know what people and the habits that nurses use within the wards. So we came together, and me being a practice development facilitator, and we used a practice development project model to develop our way of working together, and sat down and actually spent some time and several days actually looking at our values and vision, the SIP principles of collaboration, inclusion and participation, the project principles and the research evidence that would support it. Now, unfortunately, there wasn't actually a lot of relevant literature, and I'm delighted to hear that St Vincent's and UCD are going to publish something, because there's nothing there. There's nothing there that links up the electronic patient record and all of the elements that we want to achieve there. So it would be really, we couldn't find anything, so we were trying to link up things ourselves. But we set about and we tore about things. So I suppose where we are now, and we have kind of put a name on it now, what we have, we're still building it. We're hoping to go live in the 1st of November. But we've developed the Galway Clinic Complete Electronic Nursing Record that meets the standards of the NMBI. That is, the content is compliant with JCI and HICWA standards for hospitals related to care processes, and it uses standardised nursing language as defined by NANDA-I. Now, we say we're using it, but we're being informed by it, but not constrained by it. We haven't bought the licence for it. We are using the content kind of delivery really around, building around what we need for ours. So we are keeping it in our content mind, but actually not being constrained by that. And we're incorporating the NIC and the NOC, which we've heard about earlier, where applicable, because it's not always applicable, and hope to contribute to the taxonomy in the Irish and the UK context, because I think there is a different language here. The Americans also speak English, supposedly. Do you know what I mean? But we speak a different language, and I think we have to recognise that, and I think we have to, that the concepts of nursing in the Irish and UK context is very different from the US or even Canada. Canada's a little bit closer, but we cannot adopt and slice in. That's what we believe, and because we tried that in 2004. So it focuses very much on outcomes for patients, and this is what we want to do. So we're going to kind of build in our system, so it'll measure our metrics and measuring our standards and infection rates, falls and pressure ulcers, etc. And it's capturing some of our indications of person-centred outcomes, which is what we are building on to go with our person-centred practice framework. In fact, we have Professor Tanya Hans coming to us she's doing a masterclass with us on Thursday of this week. So we're a very busy week this week. To talk about how we can evaluate and build into. Now, of course, documentation is only one part of that, but we are hoping that we will be able to take some significant data from that. And there are the 4 elements that they would recommend within that is involvement in care, the satisfaction with care, the feeling of well-being, and the presence of a therapeutic culture. And we're also looking in the broader context from hospital-wide is the measuring PROMs, or patient-reported clinical outcomes, or patient-reported outcomes measurements, which they're looking at for various different clinical diagnosis and disease management processes. So we'll be working together with them on being able to pull out the data from that. There's also other data potential from this, being able to measure nursing activity, patient acuity, needs analysis, both met and unmet needs, and timely interventions. We are definitely, because we are moving more closely to making it user-friendly, and Winnie will talk about how user-friendly it is, to being able to, for nurses to use the system contemporaneously, so that we have very timely interventions when the activity is happening. And that's easy to use and not a burden to the nurse. And that we will be able to build evidence of quality of practice, or poor practice, whichever, but always quality in the Galway Clinic. Oh, and I'm going to hand you over to Winnie now, who's going to give you a snapshot.
Hi, my role within the Galway Clinic is to bridge the gap between nursing and IT. The first step in our process on this journey was to do a documentation review, and that involved customising all our documentation to meet our identified needs and stated goals. These were like person-centred language, using standard nursing language, and also facilitating real-time documentation. Once the system was delivered, then the process involved taking those paper documentation and translating them into an electronic format. One of the things our system offered us was the option of standard content. Now, we took that standard content, which was really predefined care plans, problems, outcomes, and interventions and assessments. What we found, though, with that standard content, we only used it as a reference point. It was really for another audience, which was primarily the US market. Here you will just see a screenshot of the standard content that was delivered, and just the terminology and stuff, and that's like one basic example. It just didn't really suit our terminology. Then also here you can see this is what is a work list, and a work list is a tool for nurses, and it displays all the documentation requirements for a nurse type. So a clinical nurse specialist would have a different documentation list to a ward nurse. Here you can see there are desired outcomes, which are in the purple, and then underneath there are all the assessments and the interventions. And what we found with the standard content was that each individual intervention was defined as a care item. Okay? And what ends up happening is that's only 2 problems. You can imagine if the patient had 5, 6 problems, it would get very cluttered and very busy. All right? So what we did was we created an admission assessment. Okay, so the nurse fills this in, and then using decision support mechanisms based on the patient's responses, it will actually trigger problems or diagnosis. Okay, and those problems are person specific. Okay, and then the nurse has the opportunity to accept those problems, and they will go into a person-centred plan of care. Now that also will trigger associated outcomes and assessments and interventions, as you can see there. Now what we did in the customisation process was we included all the interventions in actually one assessment, which means that for the outcome of preventing aspiration while eating and drinking, as you can see some of the elements of NANDA, but we have tailored it to meet our needs. Okay. And you will see there we have a risk for aspiration, eating and drinking. So when I click into that, you will see all our interventions are in one document. This facilitates better readback, and also nurses are just going into one place rather than multiple clicking on things. We also tried to use standard language and to anticipate what people's responses are, because reporting is a big thing for us, and also to ensure quality and consistency. You can see a lot of the answers are there provided for the nurse. Now this takes an awful lot of time to actually get that in, so it's going through all the literature, all our current documentation to get it into that process. We also had to ensure that the documentation facilitated the workflows of nurses, okay, because we want to encourage real-time documentation at the patient's bedside involving their care. Okay, so in order to do that, you have to ensure that these things like interventions potentially are only done once per shift, but ongoing evaluation could be throughout the whole shift. So what we have done is you have a separate evaluation whereby you can evaluate the problem. Is it an ongoing, that they had a successful meal, things like that, additional observations and an evaluation note. So you could do that after breakfast, lunch and dinner, okay, or as often as you need be. And with some things we customised our outcomes, because for the likes of incontinence it could be managing incontinence, or it could be that the patient is going to become continent, so we also have to facilitate that. Finally, a key component for us is using standard language, okay, avoiding duplication, and ensuring that we facilitate real-time documentation. Thank you.
Just in summary then, just to give you the picture, is that the customised complete electronic nursing system supports individualised and quality nursing practice, enables real-time documentation at the bedside involving the patient, is user-friendly, provides a comprehensive record of care delivered, adaptable and transferable to all specialist areas. So we have kind of worked with our CNSs, etc. Facilitates and promotes the use of critical thinking skills and easy audit and evaluation. And we go live on the 1st of November, please God. And I'm finished now, Edna. But we are looking at doing a research proposal on whether the development and introduction of a person-centred documentation within an electronic medical record leads to improved quality outcomes for the patients. So So we're really hoping that.
Thank you so much to Sinead, Michelle and Winnie for a very informative presentation. Just, I suppose, now, just for the afternoon now, we've actually heard quite a variety and diverse range of presentations in relation to the electronic health record, the models of care, the principles, the criteria that should inform the development of this practice within our professions. And what we would like to do now is divide the group into 4 or 5 groups, 4 groups. Mary's just said 4 groups. And I'm going to actually count the seats. 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, 1. 3 is your 3?
You wanted us to take a number, is it 1, 2, 3?
Yeah, take the number.
Okay, maybe you'd start again, because I didn't realise.
Okay. Just add